Hi, I'm Sydney. I'm going to be your student nurse today. Looks like your doctor ordered a cardiac and pulmonary assessment. That sound about right? All right, well, I'm going to close the curtain to give us some privacy here. And I'm going to go ahead and do some hand hygiene. I'm going to wash my hands and get some gloves. I am going to be touching your chest, listening to some heart rate, some breathing, and I'm going to be asking you some questions. Is that all right with you? Do you have any cultural concerns that I should be aware of? Okay. All right, well, I'm going to start by asking you some questions. Have you had any fatigue lately?
No.
Any trouble doing activities or exercising?
No.
Do you have a history of high blood pressure?
I do not.
All right. Do you have a history of stroke or heart condition? How about any chest pain lately? Any shortness of breath?
No.
Any dizziness? Are you taking any medications?
No.
All right, great. I'm gonna start by inspecting your neck. I'm gonna take a look at your carotid and jugular arteries. I'm not seeing any pulsation, so I'm going to start. I'm gonna palpate your carotids separately and gently. Okay. All right, everything looks good there. I'm going to listen to some heart sounds now. So I'm going to ask the patient to take off their shirt. If we were in a normal hospital setting, I would have a gown that I could open and close as needed, but for this purposes, we're going to have him take off his shirt. All right, so I'm going to start by listening at your second intercostal space at your right sternal border to listen to the aortic valve. All right, and at this second intercostal space on the left sternal border, I'm going to be listening to his pulmonic valve. Right, I'm going to move down an intercostal space to urge point to listen to the second pulmonic sound. And if I had heard any murmurs or hear any murmurs at any point, I would switch to the bell of my stethoscope instead of the diaphragm to listen for murmurs because they can detect low frequency sounds better. All right, so I'm going to the third intercostal space on the left sternal border. I'm going to listen to his tricuspid valve at the fourth intercostal space at the left lateral sternal border. All right, and lastly, I'm going to listen at the mitral valve at the apex of the heart. So I'm going to fifth intercostal space at the mid-clavicular line. I'm going to listen for a full minute to take an atypical heart rate. So I'm going to be listening for a while. That doesn't mean anything. I'm just listening. got a heart rate of about 80 beats per minute. Normal. Okay. I'm going to assess your vascular system. Also, when I was listening to his heart, I was listening for the S1 and S2 sounds. The S1 sound is his atrioventricular closing, which is the mitral and tricuspid valve. And S2 sound is his semilunar valves, which is the aortic and pulmonic valves. I was listening to that primarily at the April pulse because I'm hearing love and right. Now I'm going to assess your vascular system. I'm going to assess your periphery for temperature, color, edema, and any varicosities. Using the backs of my hands to assess for temperature. Looking at color, using slight pressure to check for edema on both sides. Not seeing anything, I'm looking for any evidence of clubbing, cyanosis, anything like that. First, going to assess his upper extremity pulses. First, I'm going to get your radial pulse. I'm going to go ahead and take his pulse rate again to make sure that it matches. For 30 seconds, and I've got 40 beats, which is roughly equivalent to the pulse rate that I took of 80 beats per minute. I'm going to move to your other radial pulse and make sure that it is equal. Assessing for rate, rhythm, and equality at each of these pulse rates. Strong. I'm going to go to the brachial. Got normal rates and rhythms on both of those. I'm going to check your capillary refill. Normal capillary refill is less than 2 to 3 seconds to refill. And his color is returning very fast, so that is normal. I'm going to go to his lower extremities. For his femoral pulse, I'm going to have him lay down on my table down here. I'm going to go ahead and adjust this camera. You can see it. I'm going to go ahead and push his leg up a little bit and go halfway between the anterior superior iliac spine and the symphysis pubis to find my pulse point. Apply pressure. Strong. This side as well. It is. Okay. I'm going to assess his popliteal pulse as well down here. Leg up slightly. Normal rate, normal rhythm. Assess both legs. his tibial and dorsalis pedis pulses, I'm going to have him go back to the chair. I'm going to take his posterior tibial pulse. Both sides. All right, and I'm going to do both his dorsalis pedis pulses as well. All right, and those are equal as well. When I'm feeling the pulses, I am using the pads of my second and third fingers. I am pressing hard enough to feel the pulse, but not too hard to occlude the artery. Camera back up. All right, and finally I'm going to check the capillary refill on the toes, both sides. Normal capillary refill on those two. Okay, that's going to conclude our cardiac assessment. Now, while I'm switching over to his pulmonary assessment, I am going to change my gloves because I was just touching his feet, and I'm going to be touching his neck for this. All right, I'm going to ask you a few more questions. Any shortness of breath recently? Any history of respiratory problems? Are you a smoker? Nope. Have you had a cough lately? Are you coughing anything up? I'm going to tell my patient that I'm going to check his radial pulse again, but I'm actually going to assess his respiratory pattern. I'm doing this so that he doesn't change his respirations manually. I would find him, and I'm going to count a minute again. I counted 12 respirations, which is normal 12 to 20 respirations per minute. All right, I'm going to inspect his chest. I'm going to look at the lateral diameter. Seems normal. I don't see any evidence of barrel chest or kyphosis. The costal angle is less than 90 degrees, which is normal. I don't see any evidence of respiratory distress. He's got good respiratory effort. He's not struggling to take a breath. Skin condition looks good. I'm going to ask him to lean your head forward, touch your chin to your chest, and I'm going to look at his spine. I don't see any spinal deformities. Everything looks normal, no scoliosis. I'm going to palpate your trachea now. So I'm going to use my fingers and thumb, feeling any deformities. Centered and equal. It's not deviating to either side, so it is normal. Alright, now I'm going to palpate your chest. I'm palpating for any masses, any tenderness on palpation. I'm also going to be feeling for any crepitus. So I'm going to palpate his chest pattern to make sure that I'm feeling equal on both sides. Palpate laterally. Tell me if anything hurts or feels weird. Turn this way. Palpate posterior. Not feeling any deformities there. I'm now going to palpate for chest excursion. So what I'm going to do is I'm going to place my hands near the 8th and 10th rib. I'm going to pinch a slight skin fold and ask my patient to take a deep breath. The skin fold disappears and my hands raise so he has good chest excursion. I'm going to palpate his posterior chest for tactile epidermis. I'm going to use the palm of my hand and I'm going to ask you to repeat the phrase 99 when I move my hand.
99, 99, 99, 99, 99.
All right. I don't feel any evidence of tactile epidermis. You can go ahead and turn back. I'm going to start tapping on your chest. I'm going to be percussing over the intercostal spaces. I'm expecting to hear hollow sounds over the lungs. If I heard any dull sounds, that would mean that there is a dense area. It could be a mass or fluid in the lungs. I'm now going to listen to your chest. I'm going to listen to your lungs. I'm going to use the diaphragm of my stethoscope to do this. And I'm just going to ask you to take a deep breath. I'm going to listen for a full respiration at each spot. That's going to be a full inhale and exhale. Alright, I'm going to ask you to turn. I'm going to listen in the same pattern as that. This is a zigzag pattern so that I can listen for equal sounds. everything sounds clear. I'm listening to mostly vesicular breath sounds. His bronchial breath sounds would be found in his neck area right here. His bronchiovesicular sounds would be found along his spine and on his sternum in the front. And his vesicular breath sounds cover the majority of the lung region. I was listening for his breath sounds, which were normal. I didn't hear any evidence of crackling. If I heard bronchi or wheezing, I would ask my patient to cough to differentiate between the two. Bronchi would clear up with cough. It could be caused by an upper respiratory infection. Wheezing could be caused by asthma or pneumonia. Stridor is a high-pitched sound heard on inspiration, which indicates respiratory distress. I did not hear any evidence of that. Friction rub I would have heard when I was auscultating the lungs, and any grunting would have been visibly or audibly noticeable. All right, that's going to conclude our assessment. You can go ahead and turn it back around for me, and you can put on your shirt. Is there anything else that you need from me before I go?
So,
Okay, well, I am going to go ahead and leave you with this call button here. You can use this to get the attention of any nurses. I'm going to go ahead and go over here and take off my gloves and wash my hands again. And I'm going to close the curtain for my patient.